Vlad, are you there yet? See, someone's raising their hand. We start in 30 minutes. Juha, Huan Ying, Juha. What is Juha? Vlad, are you there? Hi, Juha, you here?
Yeah. Hello. Hello, John.
Hey, how you doing?
We are fine. We are fine.
How you doing?
Morning, Professor Yukana.
Yeah, Juha, it's on the Chinese website, mention.com, which is neurosurgery news of China. It's on, you know, mention.com, right? It's on there too. So I think that's where Dr. Bin is televising it too. Now, Juha,
Yes.
can you talk to your hospital and say, hey, I want an interpreter for all
To
my
whom?
presentation to your hospital? Can they get you a translator?
Now I didn't catch.
Can your hospital? Can you hear me? Can you hear me? Okay.
Yeah.
Your hospital, can they get you a translator into Chinese? Can they get you one?
Well, I have to ask. Yeah.
Yeah. No,
It is
don't ask. Don't ask. Tell them to. We want a
Okay.
translator. We
You
want
are
a translator.
You
No
are right.
question. No questions. No argument. We want a translator.
I have to tell my chairman. So
Yes.
immediately.
Tell them that's what you want. That's what you want.
Yeah.
If they want to be known as a leading education hospital in China, they have to start.
You are right, totally right. In one life course, we had excellent simultaneous translator.
Yeah, well, as you know, it has to be a very good translator that knows neurosurgery. So
Yeah, of course.
it's not just any translator. And they don't have to be with you. They can be anywhere in China. They can be anywhere to do it. So
the combination of good knowledge in neurosurgery and good English is rather seldom in China.
Well, we're gonna bring it. We're gonna bring it. We're gonna bring what we can do. We're gonna do what
find out.
Yeah, we're gonna do what we need to do. Very good. Okay, very good. I'll be back.
Beijing
Okay.
and Shanghai, we can find maybe. Beijing and Shanghai at the metropolitan city.
At a neurosurgery center or something. So you know, just a couple of times a week. We just say, okay, we need you at this time. We need you at this time, and maybe have a rehearsal to go over it. Maybe you don't need it. I don't know.
Subin is very good, but he's very busy, of course.
Of course. Yeah. Ben is very nice to do this, but he won't be available a lot. So we need to get.
Subin can find some younger colleague to translate.
Yeah, that would be good. We ask
Yeah,
him. Yeah, he will help us. He will
Here
help
in
us.
Changsha is difficult because I know the neurosurgeons, so I would say that only 10% are speaking here reasonable English, and
Right.
to translate simultaneously is extremely difficult. So,
Okay.
as you
Yeah,
said,
we
you
will.
have to know neurosurgery and English very well. So I think
Yeah.
we
You
have to negotiate. We have to negotiate with Subin. He might find in Shanghai, in the
Yeah.
big hospital, his Huashan hospital, he might find.
Yeah. But people
This,
will help us if we let them know. People will help.
yeah. So we will go forward. Yes, that's good.
Okay. Very good. Is Vlad? Are you there? Vlad, are you there? Hello, Vlad. We have 25 minutes. We have a long.
Yeah, we are.
Okay, I'll be back. I'll be back. Okay.
Okay, I will be back. Yeah. I'm-
Vlad, are you there? Hey, Victor, I can see you, Victor. I'm trying to get you in. Usually it means not a great connection, Victor. Trying to get you in. You may need to reboot. Boy, I've never seen a guy so hard to get in, Victor. I'm pressing the button to let you in, but it's just not taken. You may need to reboot. I'm going to tell you by Facebook. Hi, Juha.
Yeah,
Yeah,
John?
let me show you. I'm going to show you where it's being televised now in China.
Hello, John.
Okay. Hey, there's Victor. Okay. You see that? You see the page, Juha?
Yeah.
It's
have it, yeah.
medtion.com. MEDTION. It's a very large neurosurgery news site. Okay, now here's your video here that's going to go on this page here once we go live. And I believe that's the show that that Ben will be translating for. Hey, Victor, you made it in. You're muted there, Victor.
Hello, Victor.
Hey, Victor, can you hear us, Victor? He's
Okay.
driving. You're driving to work, right?
No, no escucho.
¿O no escucha? Oh, well, estamos hablando. Okay. Oh, here's Ben. Hello, Dr. Ben, are you there?
Hello. Left.
Hi, Dr. Ben, are you there?
Hi, John.
How you doing?
Fine.
Good. I see you're all set up on medtion.com. Let me show you. Okay, I'm going to show you, Ben, Dr. Ben. I imagine, is this where you're translating to this channel, Ben? You see it, right, Ben?
Oh, I couldn't see
Can you see that?
your screen. Yeah, it's black.
That's where it goes, right? Yes, it's flat. Yeah, it is. But this is where it's going to go. Medtion. Is that what you're doing? You're televising to that? Medtion?
Yeah.
Oh, okay.
I sent to a lot of groups.
Okay, good. Okay, so Juha is going to speak first, and you are going to translate in the background, right?
Yeah.
And then you are going to give a presentation. Wow, double duty.
And my colleague, Dr. Liao, he will translate my presentation into Chinese.
Oh, excellent.
Yeah.
And now we found the guy.
Yeah.
He's my colleague and my assistant.
Yeah, Dr. Ben, I told Juha he needs to get a translator because you are a busy guy. You can't translate all his talks. So we need to get, if you can introduce us to a translator for Juha's hospital to retain.
Actually,
Yeah.
I think Juha's translator should be me because I know him so well, and I learned so many tricks from him, and so I can present his techniques
Yeah. It's
than the
important.
normal translator.
Yeah, it's important, I think, that Juha gets that. So, We got 10 minutes. A lot of time. Okay, I'll be back.
Okay.
So,
Is your associate here, Dr. Ben? Is he here now, the gentleman that's going to translate your talk? Is he here
Yes,
now?
yes, yes.
Dr.
No,
Zewan?
he is in
Dr. Zewan,
the
is that you?
WeChat channel. No. He is not here.
Oh, not here, okay.
Yeah.
Oh, yeah, I'll put the link of the website, yeah. Okay.
听得到吧？听得到吧？好的，好的，好的。
我也听得到，我也听得到。
好好好。
就是那个声音材料。
嗯。
这个原生那边关一下。
Vlad, are you there? That's not.
we have to take the from the lunchroom, dinner room, aquarium.
He's been working around for weeks and then twice a week.
The glass. Was that the yeah, maybe close the windows when it begins. Music.
Hello, Ben. Hello, Ben. Are you there? Ben?
Yes, yes.
I know with translators, sometimes the speaker goes too fast.
Mhm,
Does
yeah.
Juha go too fast sometimes? Or is it okay? Do you need to ask him to slow down or no?
I think it's okay.
It's okay?
Yeah.
Okay. You must be a good translator. Okay, 4 minutes.
Hello, John.
Yes.
So this is Dr. Altaf Ali from Karachi. Have you started?
Not
I was
yet.
feeling that
Not yet.
is not yet. Okay.
For about 4 minutes.
Okay, fair enough.
Is there anything earth shaking you want to say?
I was feeling guilty. I thought actually I also work in my lab. So I was just came out of my lab. I'm working on some glioma thing, the molecular biology of glioma. So
Oh,
I had
okay.
a guilty feeling that I missed the lecture actually.
Oh, no.
I really enjoy
Juha.
the
Professor Hanisnemi?
Yes.
Yeah, can you share your screen? Let me take a glance very fastly.
Do you need that to stay there?
Yeah,
Normally, I like to start.
Next one.
Next slide.
Yeah, next.
Next slide, Juha.
Yeah, next.
Što to znači?
On je rekao mi dodatno share screen. To znači kad uđeš na Viber ili nešto, imaš onu knjigu koja se zove share screen. Onda on vidi sve što vidiš na ekranu.
Aha.
Možeš da pregledaš novine i taj vidi.
Dobro je,
možeš nešto da gledaš. Eto je.
Kako da mu odgovorim?
Yeah, I know these slides. Next. Next one, please.
Next.
Okay, you ready? You guys ready?
Okay.
You're okay, Ben?
Yeah, okay.
Okay, do you mind if I take the screen off? Or do you want it on?
Yeah. Yeah, it's okay.
I take it off?
Yeah.
Okay, because I like to introduce people by the face.
Yeah.
I'm going to take this off, Juha. Okay. Okay, very good. Let's see. Okay. Okay, very good. You ready, Juha?
I'm ready. Yes.
Okay, very good. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the pleasure of having another Juha's Neurosurgery Grand Rounds. And by the way, I forgot to say, Diha Hao, Huan Ying. Welcome to our Chinese neurosurgery brothers and sisters. Dr. Bin is translating us into Chinese simultaneously, and we welcome the Chinese neurosurgery community. Okay, we'll begin with Juha. He's going to give his presentation. The theme is middle cerebral artery aneurysm. Okay, Juha, it's all yours.
Thank you, John. Hello, everybody. Ni hao. So I will speak about surgery of middle cerebral artery aneurysms. I've been working in Finland. I'm former chairman and emeritus professor in Helsinki, and now since 2 years I'm working here in Zhengzhou in China at Henan Provincial People's Hospital. So we speak about middle cerebral artery aneurysms, and this is the background for this presentation. So I have been working in Finland in 2 places, in Kuopio, Eastern Finland, and then 18 years as a chairman in Helsinki. So in both, we built a good database of the aneurysm patients. So we have very exact knowledge of 17,000 patients with 22,000 aneurysms. And out of these, more than 7,000 are middle cerebral artery aneurysms. Exact data on the databases. In the upper part, you can see that the neurosurgery was done early in Finland. Some cases were done already in end of 1930s, but main part then the operations began heavily in 1950s and then continued more and more. And since 1970, there are in Helsinki 12,000 patients and in Kuopio more than 4,000 patients. So this is the grandfather of Finnish neurosurgery. This is Herbert Olivecrona. He was Swedish pioneering neurosurgeon. He trained nearly all European Swedish pioneering neurosurgeon. He trained nearly all European. Now is something wrong. Pioneering neurosurgeon. He trained nearly. Now something wrong. I continue. So this is Herbert Olivecrona, and he was a European pioneer teacher in neurosurgery, and he operated. He was a European pioneer teacher in neurosurgery, and he operated. He was a European pioneer. Something wrong now. The sound, my talking is going around.
Yeah, I'm sorry, Juha, I fixed it.
Can I continue now?
Yes, sorry about that. Yes, sorry about that.
Okay. So Olivecrona operated his first aneurysm already in 1932, resected a giant vertebral aneurysm, and 1954 he clipped basilar bifurcation aneurysm, as also his student, last trained neurosurgeon, Einar Boom, whom I met when working in Uppsala. So they both ligated basilar bifurcation aneurysm 1954, and this is very special thing to do that without microscope successfully. And these are the grandfathers of Finnish neurosurgery. Arno Snellman, the first neurosurgeon, was training some time with Olivecrona and then came back to Finland and began to operate on. And his successor, great aneurysm surgeon Af Björkesten, who died the second year when I was a resident in Finland, Helsinki. So from the old times without microscope, there was a saying in Helsinki that you have a professor competence if you can occlude the middle cerebral artery without any deficits in the patient. This is of course seldom possible. And it looked like that. This is from the year 1953. You see very large aneurysm ligated with silk, and then Olivecrona clip added to the base of the aneurysm. And it looked in the operation room like that. This is not from aneurysm operation. This is certainly a trigeminal operation. which pillar Fraser method patient is sitting here. So this is from our databases, site of the aneurysms. And as mentioned, the middle cerebral artery aneurysms are the most common, more than 1/3 of all the aneurysms, 35%. And in several studies, we studied these middle cerebral artery aneurysms heavily. In 1995, Dr. Jaakko Rinne, professor now in Turku, made his PhD on multiple aneurysms, including middle cerebral artery aneurysms. Then Dr. Reza Dasti, coming from Istanbul, published all different sites, proximal M1 aneurysms, bifurcation aneurysms, and distal MC aneurysms. Very good papers. And then Egyptian fellow Ahmed El-Sarkawi made also his PhD of these aneurysms. And this is from his PhD occasion. You see Ugur Düre is the opponent. I'm Kustos, and in the middle is Ahmed El-Sarkawi from Egypt. So he divided the middle cerebral artery aneurysms in 4 different sites. So you can see here the M1 aneurysms, and then these are the M1 aneurysms, and then bifurcation aneurysms and distal aneurysms. You can see here five different sites, but his classification was 4. And in the picture, you see that the artery is not coming from the base of the aneurysm, but in the picture here, for the special for the M1 aneurysms, that the artery here, anteriotemporal, the artery is coming from the base of the aneurysms. This is very important for the treatment. So the middle cerebral artery aneurysms are the most common in Finnish population. They have many times multiple aneurysms. They have many times intracerebral hematomas, and because of that, there is high management, morbidity and mortality, and the series describing these common aneurysms are rather seldom in literature. They have complex cisternal and vascular anatomy. They supply important areas of cortex and eloquent areas, and there is lack of collateral circulation mainly. This is very important to note. And one more thing, middle cerebral artery aneurysms are superficial, close to the surface. So to speak about surgery, surgical strategy, there are 4 different types. You can operate on unruptured aneurysms electively. Then you have acute surgery and ruptured aneurysms. We used to operate all cases within 1 or 2 days after rupture. In the small country like Finland, it is possible. And then you have emergencies, patients with large intracerebral hematomas, and then you have very special cases, difficult to treat, large, giant, fusiform aneurysms. When planning the surgery, you have to look at the patient. How is the patient? What kind of grade the patient has? If the patient has hematoma, and then of course the size of the aneurysms, which type of aneurysm, main part are saccular aneurysms, ruptured, unruptured. I always look at the length of M1 because then you know where the aneurysm is. And in large aneurysms, you have to look at calcifications and how the parent vessels are coming close to the aneurysm. About position when doing surgery, head should be elevated clearly above the cardiac level, then you have less bleedings. rotate it only slightly. The most common error is to rotate too much. Then the temporal lip in the sylvian fissure is overcrowding. The aneurysm site is more difficult to open the sylvian fissure. I tailor always the head position, thinking how the aneurysm is directed, and you cannot say exactly how the head position is. You will see in the coming videos. You should have a good working angle with the mobile microscope, with mouth switch. You can always reach that very well. Oh, this is the craniotomy I have been using since 80s, this lateral supraorbital approach. We don't shave the head. Please note that. I will come back to that. Minimal shaving, only for the operative area. Prepare well. Infiltrate with lidocaine, adrenaline, or other derivatives the wound to have less bleedings. And then I'm making single layer flap. My knife is going through all the layers to the skull and retract it as a single package. This means that there is no or minimal temporal muscle atrophy later when the patient has recovered, and there are no frontal facial branch injury. And when dissecting toward the aneurysm, I usually open the sylvian fissure with a needle attached to tuberculin syringe, use water dissection to distend the sylvian fissure, and then open very focused around 1 inch the sylvian fissure and use sharp dissection usually towards the aneurysm. There are four different types of aneurysm directions, like Reza Dusty published after analyzing these cases. This aneurysm is directed to the sylvian fissure, and you have to know which direction the aneurysm is pointing. This means a lot in surgical surgery. Then in the fresh cases, as I mentioned, we operated in the first 2 days because the patients were quickly transferred to us. So you have the red, angry, swollen brain after subarachnoid hemorrhage. You have to change it to slack brain, and I usually use lamina terminalis opening. Then we had excellent anesthetists in Helsinki. They had their tricks, and usually the main note by the visitors was how the brain can be so slack, given there was a heavy subarachnoid bleeding and hematoma. I seldom used ventriculostomy, but I left ventricular catheters through lamina terminalis in the third ventricle. There are many patients had mirror aneurysms like here. Many of them you can do by one-sided flap, also clipping contralateral branch. In this case, could be done from left-sided flap. So we go to the videos now. First case is very small middle cerebral artery aneurysm, video edited by Daniel Kochurov, now working in Israel. Is 51 years old female. It's difficult to see in the CT angio the aneurysm, but it is medially pointing M1 aneurysm. And from experience, we know that the CT angio is not showing all the side of the aneurysm. Here I go to right lateral supraorbital approach, now with the needle opening the sylvian fissure. This is very cheap, good knife. The needle magnification is very high, and then I go directly through this small focused opening to MCA and towards the aneurysm. The aneurysm was pointing upwards, so we have to find it on the superior surface of the MCA. We don't see it yet, but soon. Minimal resection of the frontal lip, and then we come to the aneurysm. You see that there's a small patty. I didn't use threads in these patties. Here in China, I'm not allowed to do that. Now we see the aneurysm, and you see it was extremely small aneurysm in the angios, CT angios, but it has also extremely thin wall. There is a small, thin walled area, and it is easy to understand that these aneurysms rupture. So half of the ruptured aneurysms were less than 7 millimeter in our series. Now I took a curved clip because you have to save behind the sac is the anterior temporal, one big perforator, and this is very crucial to save it. Otherwise, the patient will have severe deficits. This was IC angio, and now I coagulate down the aneurysm, add some hemostat there, Tacocil, and pack Sylvian fissure. Like a teeth, I closed the door after clipping of the aneurysm. And these are the postoperative controls. You see, it was rather proximal aneurysm. And this was the team doing the video, and we go to the next one. So this is ruptured left middle cerebral artery aneurysm, video edited by Jane Lau in Hong Kong. So this is CT, left side more blood, and again very small aneurysm. We used only CT angio to diagnose the aneurysms, because when we saw the patient was brought by ambulance to us, we made CT. There was a subarachnoid bleeding. We immediately made CT angio, and then the patient was, with good pictures, ready to operation. So many of the cases were operated even on the day of the rupture. And here, tight brain, I went to lamina terminalis, opened the lamina terminalis, and here is very important, slowly suck the CSF out. And then when you have slack brain, then you can go to the aneurysm. But you should not begin to dissect the aneurysm if the brain is not slack, because if you put your spatulas on the frontal and temporal lobe, you will have contusions, brain damage in both lobes, like it was shown by Dr. Riku Kivisaari in his PhD work. So now dissecting it looks totally different. There's a lot of blood, fresh blood after fresh subarachnoid hemorrhage. One of the advantages of the fast surgeries that there is less scarring, so you can suck all the blood out when you operate late, like we used in 70s. So you had more scarring with waiting. Now dissecting the MCA, putting golden color temporary clip on the middle cerebral artery, and now we are going towards the aneurysm. You will see here is the aneurysm, and there's the CT angio picture, and you will see also under the sucker is the rupture point from both, and this is the first clip pilot clip, taking the base of the aneurysm. Then I remove the temporary clip. You should not take temporary clip immediately out, just open it, because if it bleeds, so it might be difficult to put it back. And now I coagulate the aneurysm, smaller, change the clip, suck with sucker the aneurysm inside the clip, and change many times. Where I have temporary clip in the place, so there is no danger of the heavy bleeding. And coagulate down the aneurysm, and this is ICG. Was not I was not happy with the clipping. You should continue as long as you are satisfied, but you should not try too hard, because then you might occlude the bifurcation. So then again, closing the Sylvian fissure, and this is post-operative CT, done usually next day. Next. And here is unruptured right middle cerebral artery aneurysm. This was a growing aneurysm. Patient is the sister of Guido Guglielmi, the pioneer of the endovascular surgery, coiling of the aneurysms. He was visiting Helsinki. We had very good time together, and he sent her sister for surgery. This is the lateral supra of the approach, right side. And now again, under high magnification, opening with needle, Sylvian fissure, injecting water inside the Sylvian fissure, expanding the Sylvian fissure. And these are Kamiyama schizos, very good microschizos, very expensive also. When they fall down, then they are destroyed, and so in this way you lose them easily. So going through distal opening of the Sylvian fissure, we go to the aneurysm. It looks as very thick wall, but soon we will see which pleb was growing. So it is here, below the cotton. There is a very thin-walled part. We don't see it yet. I'm dissecting under high magnification. Oh, what happened? I made something stupid. I made something stupid. Oh. But it was in the middle. Sorry, it was my mistake. Not running. We take the next one. Okay, I cannot run this video, so it now we have big difficulties, technical difficulties. We have to restart the PowerPoint. I'm extremely sorry now.
In the meantime, can I ask a question?
Yeah, of course.
So, do you have any experience of coiling the aneurysm which has ruptured? Have you ever advised coiling to patient who has ruptured aneurysm?
In the middle cerebral artery, aneurysm should be clipped. Anatomy is totally different from other aneurysms. I will come back. I think even the technical advances in treating middle cerebral artery aneurysms, they should be treated by microsurgery. Of course, I'm now working in China, so this is a place of endovascular surgeons. So maybe 70% of the aneurysms have endovascular treatment here.
And how about ACOM aneurysm which has ruptured? Have you ever advised coiling to a ruptured, not unruptured?
During my time in Helsinki, nearly all aneurysms had microsurgery. After that,
right, so you will always advise surgery, microsurgery to a ruptured aneurysm, no matter where it is. Am I right?
no. You are not right. You are not right. We are speaking now about middle cerebral artery aneurysms.
Right. I digressed because your video was
For
not
my
working.
middle cerebral artery aneurysms, I would always say that they should be clipped.
Okay.
Okay.
Thank you. Your video has started.
Yeah. I'm sorry for. So this is the same case. This is the sister of Guglielmi. I'm sorry to begin it again. It was my stupid mistake. My finger was on the wrong place. So again, we repeat focused opening of the sylvian fissure here with under high magnifications with the needle and then injecting water inside the sylvian fissure and then opening here, careful dissecting. This is of course anatomy is here very clear because you have there's no blood disturbing the anatomy, and I was speaking that the aneurysm wall looks extremely thick. White is growing the aneurysm. It looks that there is also some hemosiderin. That's not ruptured, so we know very well there was no strong headaches. But we will soon see the teeth that has been growing and has very thin wall. So, studying the anatomy now, dissecting the aneurysm away from the brain, opening more widely the sylvian fissure, and then now you see the thin part that was growing. You have to find both M2s, and now I put temporary clip golden color on the M1, taking care that the small perforators are not inside the temporary clip, and now I take a J-formed clip on the broad base of the aneurysm, take the temporary clip out carefully, because the handle may be attached to the small arteries or veins close to the handle. So you have to take very carefully the temporary clip out. And now dissecting more try to coagulate now the aneurysm, but the final solution is to put one more J-formed clip in tandem there and then add small clip to take the ear ducts. There is some small part of the base, so I add one more clip there. And this is the final solution here. And then this is Doppler, mini Doppler. It's very good and fast, and you can repeat it many times. And then we did also ICG, and it showed good feeling of M2s. Next case. Video edited by Juha. These videos are 1001 videos. You can find them in internet, around 1600 videos, searching by Hernasniemi, and 1001. This is a coiled aneurysm. Italian patient had MCA aneurysm coiled 1 year after coiling. Again, opening at Sylvia fissure, injecting, expanding the Sylvian fissure, and then opening the Sylvian fissure. And this aneurysm, the difficulty was that the coils were partially in M2. So it looks now easy, just put the clip. But what happens here? So the clips inside the aneurysm are pushing the clips down to the bifurcation, and this occluded. So you don't have any flow. The bifurcation now. The clipping is too tight, so the bifurcation is totally closed. Now what we are doing, so we are traveling with the clips, try to go higher, but solution is you have to open the aneurysm, and actually it looks rather dangerous now if there is enough base left. So I take a curved clip and second one, and this way I could reconstruct the bifurcation. There are coils which are cut, and 1 year later they are attached to the aneurysm wall. So it is by far more difficult to remove them than quickly after coiling. And this is now the very important ICG, and here postoperative DSA, which was rather uncommon. We didn't do DSAs after operation, just CT angios. So the patient did well and was flying home in a few days. Next case, I tried to select a huge selection of the videos, cases which Tian, Chinese fellow, edited this. So here is a large MC aneurysm, unruptured, like a ball, short incision, injection of the local anesthetic and adrenaline derivate, and then this is the LSO craniotomy with one burr breaking the plate, drilling away bone, and then opening the dura. Very fast opening. In this 10 minutes, dura is already open, counting from the skin incision. And now we go to the aneurysm. It was directed to the Sylvian fissure, so it will come first here. Here I have a small bleeding from a vein. Pack it with patty and then inject water around the aneurysm. It's called water dissection. And now, that kind of aneurysm you cannot clip without temporary clip. First clip to go is here, ring clip, because the aneurysm can expand through the fenestration and clip is not slipping out. And this rather complex aneurysm, I put the first clip rather early to compress the aneurysm together, and it is not in accurate position. So the position is changed many times with progressing dissection. I take the temporary clip out now and change the clip positions. Travel with 2 ring clips, and then I note I have to dissect more M2 away from the aneurysm wall. Put again temporary clip, and then again ring clip. The aneurysm remains strong, still strong. So I add more clips to kill the aneurysm. Doppler. And now there are 1, 2, 3, 4 clips. I'm still coagulating the aneurysm that is filling, so I add long clip in the middle of the fundus. A row of clips there, checking M2s. And now finally, I didn't see the ICG well, but must have been well, and these are post-operative pictures next day. Next case. Again, edited by Jiang Jian from China. Here's a ruptured large MC aneurysm. I was speaking about the hematomas. We operated large series with big hematomas and have also published that already in 90s, the series. This is again lateral supraorbital approach. This is Sukita frame has extremely good retraction system, and now you see that the red angry swollen brain is coming. I think it was Dr. Drake, my teacher, who introduced these terms for the badly looking brain. Red, angry, swollen brain. It is very good description here. Now the dissection is totally different here because you have swollen brain, blood, and now I have to find the MCA for temporary clip. And it is behind and below the aneurysm. So now I put the curved temporary clip proximal to the aneurysm, and now the aneurysm is more soft and I can dissect it, but the angle for clipping is not good. The direction is not good. You saw that I was trying to put a clip with my left hand, which is not so good as the right one. And then I'm, with the help of this clip, I go to the hematoma, take hematoma out, and then the brain is more slack. But now there's long fight to have proper clips on the base, large base of the aneurysm. And now Doppler, checking M2. You have to have good flow, otherwise the patient has cerebral infarction. And now dissecting around the aneurysm, changing the clip positions. The length of the clip should be 1.5 times of the base of the aneurysm. This one I learned from Dr. Craig, and I was thinking why it is so. It is simple geometry. So when you flatten the ball, then it is around half a p, the length. So in 6 millimeter base, you have to have 9 millimeter clip and so on. This is ICG, and now it looks that there's some aneurysm left in the video. I was not so happy with, but in the angio it looks good. And this is a giant left middle cerebral artery aneurysm. Young patient, 13 years old, had temporal epilepsy. And you see there are a lot of calcification. I was looking at this aneurysm and I was thinking at the base there is no calcification. I could clip it. And this is the patient 2 months after surgery. He was doing very fine. She was doing very fine and is now a chemist in Lapland. So now we come to more difficult aneurysms. Here's a thrombosed giant aneurysm. Patient has also anterior communicating aneurysm. It was decided to treat those both. First, the giant aneurysm, and then to go for the anterior communicating aneurysm. But because of the complicated surgery, we left anterior communicating artery aneurysm alone and made it in 2 months when the patient had recovered. So this is one of the principles. If you have the difficulties with the first aneurysm, don't go to the second one. You should be able to stop. So now, temporary clips. Aneurysm is trapped. You cannot clip without temporary clips. This aneurysm, and there is no coming back. You cannot regret here, because when you go with knife inside the aneurysm, you have to treat the aneurysm. I'm seldom using CUSA, but to take the thrombus out is the best thing. And this is the DBG, vascular clamp, aortic clamp, compressing the aneurysm. We can take the temporary clips out, and then we have time now to dissect. Now it is bleeding. Now it is bleeding. So I take a ring clip. And again, put temporary clips. Now again, aneurysm totally isolated. M1 and M2 have temporary clips, and then I take thrombus out. In that kind of giant aneurysms, the origins of M2 might be very hidden, and there might be thrombus, and so they might be occluded when you are clipping the aneurysm. So one part of the broad base was left, and you see ICG, both M2s are closed. Even there's a lot of space at the base. So we have to put temporary clips and check inside the aneurysm. There's some thrombus occluding the orifices of the M2s. So I went there, cleaned, and clip again. Ring clips, and then you should of course close the fenestration with the straight strong clip. Now changing the position here several times, trying to understand how it is inside the base of the aneurysm so that the M2s remain open. And now the straight clip is occluding the fenestrations, and now take the temporary clips out, and now it looks better. And checking with Doppler, and now ICG, M2s are open, and then papaverine around M1 and M2, and then closing, and this is post-operative next day. This is Perapong Tiarafat from Thailand. Here we have a distal MC aneurysm, and the trick here is that they are extremely difficult to find. So if you can navigate, use the navigator. Here we see rather complex looking distal aneurysm. The incision should be a little bit more posterior than regular lateral supraorbital approach, and we have to open more posterior here to come to the distal aneurysm. So now you see what happened. When opening here distally, I hurted the vein, it's bleeding. I inject water there, still bleeding, and then I have to sacrifice the vein. Then opening here, and now you see the difficulty. I don't find the aneurysm. And this is how it is. If you see a distal MC aneurysm, so be very careful in localizing it. So I open here, I sacrificed one vein here, and I didn't find the aneurysm. So we have to search another place. So I didn't find that. So I made stupid mistake in localizing. Now, based on that experience, we go different place, and now we come to the aneurysm. But even now, it is not so easy to find. So if you can use the navigator, use it. Now we find. Maybe third place I'm searching here in the archipelago of distal Sylvian fissure. So now we find the aneurysm. And it has two putties. I put one clip below. There's some venous bleeding. And then the other putty is here. I'm dissecting it. Put the clip there. Take a small ring forceps and draw the sac inside the clip. And for some reasons I was not happy, because it is like the aneurysm is expanding in both directions, so I changed here a curved clip, and again it is sliding now. Now I have to do the trick again to take the small forceps and to draw the aneurysm inside the clip so it holds. If the clip is sliding, so it might be helpful to put the temporary clip here. So the aneurysm is more soft, and now it was ICG, and you see the postoperative CT angio here and the position of the clip, distal position, and once more, they are difficult to find. And this again by Perafon, edited. This is bilateral mirror aneurysms. So you see both side MC aneurysms, and you can do them by one-sided approach, but you have to select the side well. Here we are going from the right side to have contralateral approach is only possible if the aneurysm is direct inside the sylvian fissure. Well, so now we are going from the right side again, as shown in several videos. This is water dissection to expand, open the sylvian fissure, and then to find the bigger aneurysm. It's coming now, slowly. So this is again focused opening of the sylvian fissure. We are going straight to the aneurysm. Here we can see M1 below the schizos, Kamiyama schizos. M1, and this M2. This is unruptured aneurysm, so probably we can treat without temporary clips. Dissecting carefully and coagulating. Now I don't know what I'm doing here. It looks not very good surgery, or yeah, there must be some thinking. Okay, I was dissecting the fundus on both sides and now compressing the aneurysm with my forceps and then put in the same direction, I put the clip. Now, this was a slow dissection and looked tedious, difficult. Put the pilot clip, first clip. And then the second one below the first one to take all the base. Here you have to be very careful that you don't take all the bifurcation, occlude the bifurcation. So it is balancing in the clipping of the MCA aneurysms. So the bigger is the aneurysm, the more you have to leave the space, like in the case where both M2s were occluded. So you have to leave a lot of space because the wall is thick, and when compressed together, you might occlude the bifurcation totally. And now I'm playing with the clips. So now I take this clip out, and now it is in the upper corner. I don't see well, but now I'm coagulating out the aneurysm. And again took the clips out, coagulate down the aneurysm. Was directed in two directions, the aneurysm, and now I have coagulated it down, very small one, and should be able to clip with short clip. You see there is a venous bleeding, disturbing situation. And now the small clip is taking all the base of the aneurysm, and then we have ICG angiography, and now we leave this place. This was the right MC aneurysm, rather complex aneurysm, difficult to treat, and still changing the clips. This is final clip now. Okay, then we leave this. Now I have difficulties to understand now. Now I put temporary clip. This has many putches, this aneurysm. Yeah. But I have two aneurysms. I'm sorry, now I'm confused. Okay, this is the bigger aneurysm now. There was a small aneurysm I was treating, and now okay, now this is coagulated down, and then the clip is going there. One more clip. Okay, now it should be ready. Checking. When you are at the place, you have to check carefully because this is the best possibility to happen. This is wrong video. I have to take a look now. Can we go to the beginning now? I was explaining wrong. I clipped first. I have to check this one. I will study this video better. I will explain next Friday because I'm late now. So this is a patient coming from France, had a 7-centimeter aneurysm. We did Elana bypass, and you see the black bloody sausage is the thrombosed saphenous vein, which was used to bypass the aneurysm. I'm opening the aneurysm now, and you see a huge number of thrombus coming out. And then I put a temporary clip proximally on M1, continue taking thrombus out with CUSA. And then cut the aneurysm, resected the aneurysm, and what I did in this case, this is again the Becquet clamp, because it helps to collect the base of the aneurysm and then makes like a road for the big clips. And I'm compressing the aneurysm and then cut the aneurysm out and then put suture base, and then on the road that the Becquet clamp has made, I put the big clips and suture them in place also so that they cannot slip. So this was the solution. And the patient was coming with 2 taxi drivers from France. She was talking all the time because she had temporal lobe compressor and that kind of mental disturbances. But after surgery, she recovered extremely well and lost her fear for flying and became more silent, not speaking all the time. So difficult surgery. We failed in the bypass operation, but could correct with the resection of the aneurysm. So I finished with the videos. I'm very sorry for the technical difficulties and for the one video I couldn't explain very well. So finally, I again come to the point, don't save the beautiful Chinese hair when you are doing neurosurgery. Chinese females have extremely beautiful hair. It is a pity that It looks here in China, in most places, like that. You can save the hair. You see here this 10 years old girl after AVM operation, parietal AVM operation. She could go quickly to school after recovering from the surgery, and she was very happy for her hair. So middle cerebral artery aneurysm series are published seldom. They are common, but every case is different. And because there are very few collaterals, so you have to take care of the flow very well. Vessel occlusions might happen, and then you have large infarctions, and many times you have big hematomas. They may lead to permanent deficits, and I still think that these special aneurysms, middle cerebral artery aneurysms, are best treated by a clip, by microsurgery. This is sub-selection of the series. You see that we have operated extremely poor grade patients, and you see that the mortality is in these cases high, but you can save also lives with good recoveries in also low grade, deeply unconscious cases when you treat them properly and in time. And there's a lot of discussion that to open the head is dangerous. It is our profession. We should not be afraid of opening the head. If somebody is opening the head in dangerous way, should stop to do neurosurgery. So finally, concluding, middle cerebral artery aneurysms are superficial and should have microsurgical treatment to have long time good results in follow-up. And what is important in operation room, this is from Henan Provincial People's Hospital, our operation room, good team to do the surgery. No one is doing alone the surgery. So thank you very much, JJ.
Okay, Juha, thank you very much. Okay, let's start off with comments or questions from Vlad. Are you there, Vlad? Perhaps he stepped away. Or Dr. Ben, would you want to start things off with a comment or?
Yeah, very nice presentation. Because I'm translating, so they call me should mute in this side. Otherwise, there's some echo.
Oh, okay. Yeah, I'm sorry. I'm sorry about that. Okay. Okay, Luis, ¿cómo estás, Luis? ¿Tiene comentario o preguntas?
No, it's difficult to my comment because the only comment, see, I work, see Juha work in Madrid, I don't embolize never more. It's my comment. It depend not of neurosurgery. It depend of neurosurgeon. Understand?
Okay.
Congratulations, Juha. Fantastic.
Thank you.
Okay.
Thank you.
Other questions or comments? Hello, Manuel in Russia.
Hello, John. How are you?
Good. How you doing?
All good.
How are things in Moscow?
The weather is Moscow weather. You know, it's cold, already cold.
Okay.
I want something to say to Professor Juha. First, thank you for the speech. Days ago, we have a patient, and I have the opportunity to comment to him. Was a big aneurysm in the segment before of the vertebral artery, and the approach on the surgeries was embolization, but the patient didn't have good outcome. And after that, have a compression on the brainstem, and now the patient is brain dead. So I was commenting to Professor, what was the best approach for such big aneurysm and so complex in the basilar vertebral segment?
I will answer you privately. So because the other guys don't know the case, it was the very huge aneurysm in the vertebral artery. So I will answer what is could have been my solution. So thank you for the.
Okay, Professor. Thank you.
Thank
Okay,
you.
very good.
Nice to see you, Manuel.
Okay, other comments, questions from the panelists? Okay, very good.
Excuse me, can I have a question from Professor?
Yes, go ahead.
You showed that all of your approach for the MCA aneurysm was opening of Sylvian fissure from the lateral. But my question is that if there be rupture of the aneurysm, you will not have proximal control and your field will be full of the blood and you have not any proximal control. So you don't think about it that we consider opening of Sylvian fissure from the proximal to consider carotid controlling or M1 controlling if the aneurysm be ruptured? This is my question. I know that you are sure from yourself, but you consider for every 10 aneurysm, every 100 aneurysm, maybe one of them be ruptured. So your field would be full of the blood. So you have not any proximal control.
Now you were speaking about the complications I didn't have. You were fearing them. So I have been thinking and studying all the MCA aneurysms, and I'm always tailoring the approach. Even I open distally, so I go to the M1, and I have very good proximal control. I'm using temporary clip more often than not. If you look carefully at these videos, there was, in most cases, there was temporary clip in the place. As young neurosurgeon, I couldn't understand why are you going first down and then come back. So I began to open distally already more than 40 years ago, and I can go to the M1. So it is not a flood of blood or coming soon. Of course, if you are doing improper surgery, you have flush of blood, but you have to go, your goal, even opening distally, is to go first to M1. And if you study anatomy, you can go carefully to M1, so to have control. So please read our papers, so you will find the answer, but that kind of sudden rupture we didn't have, or I didn't have. This is an experience of more than 2,000 MCA aneurysms. But in the beginning, I was already doing well because I studied the direction of the aneurysm.
Very good. More comments? More comments?
I have another question from Professor. Somebody present in the papers that we can going from the one side of the brain going to other side of the MCA in the other side, the other brain for the clipping. What's your opinion for their approach? Do you believe them or no? You don't advise us for this approach.
I think if you want to make contralateral approach, you have to be experienced neurosurgeon. I wouldn't advise to do that if you are not very experienced neurosurgeon. But when you have done many cases and you can understand the anatomy, then you can select the right cases and you can do it. My co-worker, Dr. Hugo Andrade Balazarte, made his PhD on this contralateral approach. And maybe we can take in future a presentation on that, but you can do it safely. safely, you can do it. But you have to be able to select the right cases and be able to work in a deep gap. So I don't recommend it, but those who are thinking of it, that they are skillful enough, they can do it.
Another question,
But
Professor. Yes. Another question is, what's your opinion for the anti-epileptic drugs? We must use anti-epileptic drugs for the patients, all of the patients. You don't believe for the anti-epileptic drugs for the patient?
For middle cerebral artery aneurysm is good to use.
For all of the aneurysm. For all of the aneurysm.
No. Listen to me. For middle cerebral artery aneurysm, you should use because they have many times hematoma. They have manipulation of the Sylvian fissure, but not for all aneurysms.
Yes. And another question is that what's your opinion? I know that you, for the early patient, for the first 3 days, you will operate the patient in emergency condition. But if after 3 days and patient would going into the vasospasm, what's your opinion? We must wait and watch to finish the vasospasm course, or you believe that we open the patient and clip the aneurysm, and after that elevate the blood pressure for controlling of the vasospasm? What's your opinion for the vasospasm patient? We must wait and watch, or no? Also, or no? We also can opening and doing the surgery, and after that elevating the blood pressure to about 18 or more to the better from the vasospasm. What's your opinion?
So I have been beginning my surgeries during the time we were waiting. And if the patient was not in good condition, no surgery was done. But if you then later will learn that those patients who are not deteriorating, if the patient is going downhill during one day because of vasospasm, you should not operate on. But if the patient's situation is stable and there is vasospasm, so we operate on higher blood pressure level.
But if we operate after operation, we can elevate the blood pressure. But with a ruptured aneurysm, we cannot elevating the blood pressure for controlling of the vasospasm signs and symptoms.
After vasospasm is not preventing new rupture, so we should treat the aneurysm.
Okay.
We should treat the aneurysm, then we can go high with the blood pressure.
Okay, thank you very much. Thank you very much, Professor.
Okay, more questions, comments from the panel?
Dr. Bennett?
Okay, Juha, thank you very much.
Thank you very much. Thank you very much. Sorry for the technical difficulties.
That's okay. Now listen, well, you can ask later, Altaf. Juha, do you have a topic or a theme for next week, next Friday? Are you thinking about it?
If Subin agrees, we could speak on carotid aneurysms, proximal carotid aneurysms.
Okay, great. Okay, we'll see you then.
Yeah.
Okay, now we begin with the next presentation with Professor Bin Zhu from Shanghai, who was also double duty translating too, as well as presenting. So we welcome Dr. Bin. It's all yours, Dr. Bin.
Okay, thank you. So can you see my screen?
Yes.
Okay. Thank you. So this is my topic, bypass for complex MCA aneurysm. So just like Professor Juha mentioned, the open surgery is still the best choice for MCA aneurysm because MCA is quite superficial to achieve. And this is a clip reconstruction for the giant aneurysm, MCA. very big one, because this segment still have some important perforator. It have to be protected very well. So this is I used 11 clips to reconstruct the blood flow cavity. So this is another one. 2 pouches with 2 clips. So the intracranial giant complex aneurysm, we use a lot of bypass technique to treat the giant and complex aneurysms, because by now the interventional treatment still have high recurrence rate and delayed occlusion of parent artery and perforators. And sometimes because we use a lot of antiplatelet drugs, so bleeding after treatment is still a big problem. For direct clipping surgery, sometimes it's too large for clips, and the calcification of the wall makes the procedure very, very difficult. And the protection of the perforators is very difficult also. So this is a case of a flow diverter. It have a higher risk of bleeding comparing to clipping. So this is a boy, 10 years old, M1 big aneurysm. We can see there's a lot of LSA originated from the cavity, the dome of the aneurysm. So we treated with a pipeline with coils, but the second day, it have a hematoma distal of the MCA. So we remove the hematoma and do the creotomy. So after 6 months, the final result is quite good, but the patient is recovered quite well, because but still have some problem. So bypass is a hemodynamic treatment for MCA aneurysms. Bypass normally combined with direct occlusion of MCA, or sometimes combined with distal occlusion of MCA, sometimes combined with trapping of MCA aneurysms. So the purpose is decrease the pressure of the aneurysms, keep the blood flow in perforators, and keep the blood flow in distal parent artery. Sometimes we also use protective bypass, get more time of temporal. So this is the preparation. MEPS EP monitoring is routine in every complex MCA aneurysm. The ICG flow 800 is helpful in selection of the recipient artery. And the hybrid operation room is the best choice. This is an intra angiogram in the operation. We can see the distal bypass with the blood flow recurrent to the M2 segment. So this is our MCA aneurysm strategy. It was published 2 years ago. This is a fusiform MCA aneurysm. If it's a non-dissecting fusiform aneurysm, if the LSA was not involved, the clip reconstruction and or wrapping can achieve. If the LSA was involved, we use partial trapping combined with high flow ECIC bypass. If it's a fusiform dissecting aneurysm, we normally use the partial trapping combined high flow bypass if it's located to the bifurcation, the distal 3 trunk combined combination bypass, sometimes use a radial artery combined with the STA-MCA bypass. If it's there's 2 trunks was involved, we use proximal occlusion combined high flow radial artery bypass or double STA bypass. If it's only 1 trunk was involved, we use a partial trapping combined with a low flow STA-MCA bypass. If it's M2 segment, normally we use STA-MCA bypass. That's enough. So my personal principle that the surgical plan should be as simple as possible. The bypass time is should be as fast as possible. The number of the stomas should as few as possible. For the MCA territory, blood flow replacement. For male patient, normally 2 STA branches are enough for replace the whole MCA territory. For female patient, normally the STA was thinner than the males, so STA double branch was not enough. May need the radial artery transplantation. So one STA branch can create double barrel bypass to increase the donor flow.
You okay there, Ben? Dr. Ben? Think, are we losing audio there?
Yes, we have lost the audio.
Yeah, okay. Just hang on. The Wi-Fi will reconnect. Can you hear me, Dr. Ben? No, he'll reboot once he realizes. Just hang in there. We'll edit this out. There we go. Okay, he realized he's rebooting now. And of course, once he's out, he'll realize something's going on. Dr. Ben, can you hear me? Hi, Dr. Ben, can you hear me? Not yet. Well, this happened before. He'll come on. You're muted, Dr. Ben. We can't hear you. Can anybody else hear?
No, we can't hear. We can't hear
Okay.
Dr. Ben.
Yeah, just let me know, Rakesh. Okay, he's unmuted. Can you hear me, Dr. Bin? Oh, we fell off. Okay. Can you hear me, Dr. Bin? He's on the panel. Oh, fell off again. So he must be in a pretty unstable connection in Shanghai. Okay, he's changing the screen. Now he's off again. Okay, fresh start. Just hang in there. He'll be back. We'll give him a few minutes here. Oh, he's coming back. Okay, here he is. I think we'll be okay now. He's coming back in. Dr. Bing, can you hear me? He's,
I think he has a problem. Is there any speaker next?
can you hear me, Dr. Ben? I thought he was in there. He was in there momentarily. He's worked so hard, translated, now presenting. I don't want to just arbitrarily go on to the next presentation by Lewis without seriously giving him a shot of coming back. He's worked hard, translating and presenting. Oh, he started screen sharing. Okay, he hasn't done that in a while. Dr. Ben, can you hear me? This is kind of excessive. You know, see, I don't know what to do here. What do you think, Juha? Should we go on to Lewis's presentation or we want to wait? What do you think, Juha? Oh, there he is. Okay, great, great. Go ahead. We can't, you're on mute. Can't hear you. Can't hear. I can't hear you. Can you hear me, Doctor? Can you hear me okay? Okay, we can't hear you. Can you text what you want to do? Can you hear me now?
Yes.
Dr. Ben?
Yeah.
Okay, go ahead. Let's
Yes,
continue.
yes.
Carry on then.
Yes, can you hear me?
Yes, we can hear you.
Okay.
Now we have.
Now can you see the movie? The video?
Not yet, not yet. Looks like it's loading up.
Okay, I will skip the video.
Okay.
You can hear me now?
Yes, we can hear you.
Okay. So this is a type 1.
Excuse me, Doc, we can't see your screen at all. We can't see anything on the screen. Yeah. You need to complete the screen share.
Okay.
Still not sharing.
Not sharing?
No, it's not sharing. It says starting sharing. Yeah, okay, see, that's it. Start again. Start again.
Is it? Can you see the?
No, it just says started screen sharing. Double click to enter full screen mode. Maybe double click on the screen, maybe that might work. Back to the start. Try again.
Okay.
Take your time.
You still can't see the. Can you see the?
It just says you started screen sharing and a big black screen. So it doesn't seem to be moving forward. Doesn't seem. It could be a clash with the other programs you're using, maybe. I don't know. Now, if you've rebooted already, right?
I'm sure this side. It shows that I sharing the screen very well.
Yeah, it says no.
No.
You just started screen sharing.
You still couldn't see?
Just the start screen. It doesn't really move forward past the black screen. Do you want to send me the PowerPoint? I can present it, maybe.
It's too large, you know.
Oh, it is?
Very
Okay.
large. Yeah.
Oh, okay. Yeah, videos and stuff.
Can you see it now?
Yeah, just the black screen, the same thing.
Okay.
Are you seeing, when, does it say click? Oh, wait, something happened there. Oh, no, you're back to normal. Yeah, just fiddle with it. Usually you can figure it out.
Message or you can type.
Yeah. here.
Okay, it says you're starting sharing, and then it stops. It says double click to enter full screen mode. Okay, there you go. Okay, okay. It looks like it moved forward, okay. It's a poor resolution slide. You see what I'm seeing, right, Dr. Ben? You see the screen, right, that I'm seeing?
Can you see the screen now?
Yeah, I can see it. I can see your cursor moving, but it's a very poor slide. Poor resolution. Can you move it forward? The resolution is not good at all.
Not good.
No, not the resolution, no. It's totally different. You really can't read the screen. You want to try to reload it again? Well, you know, we could do the presentation next week if you want.
Okay.
Why don't we do that? Why don't we go on to Lewis's presentation, and we'll do yours next week. That's in its entirety.
Yeah, maybe I can try later.
Yeah. If you get it going later, just let us know. Okay, very good. Okay, I have the pleasure to introduce Luis Lopez Ibor. He's going to do a presentation. Okay, Luis, it's all yours.
Okay, how are you? Thank you very much. Good afternoon, good evening, good morning. Okay, I like to present some tips and tricks of the complex, just a minute, compartir. No, I like. My presentation is this. Just a minute. Compartir, ¿cómo hago? John.
Yeah, okay. You're gonna make the PowerPoint bigger?
Just a minute.
Yeah. There you go.
It's okay?
Yes, now it's good.
Okay, I present only 2 or 3 cases with the complex bigger aneurysm, medium size of giant of the middle cerebral artery. It's a challenger of the endovascular team. Why? Because some cases have feeders born in the sac. You are the superior branch and inferior branch of the middle cerebral artery, AP view, lateral view. And this is the 3D reconstruction. You are the branch, come to the sac. It's difficult because when you embolize this, you are at risk to close this branch. But this is the neck. And in my opinion, some case, this image is not totally true. This is the 3D reconstruction. Probably the neck is only this point to this point. But when you embolize this type of aneurysm, you need every time to use the balloon remodeling. And then, if you want, you complete or change with stenting, standard stenting, 1 or 2. This is a case. But where is the question? The question is when you navigate with the material and with the catheter on the guide wire, you change the geometry every time. You change the geometry of the anatomy, of the normal anatomy. And when you remove the catheter or guide wire, you change the anatomy, and it's possible you have a complication. Okay, this is the aneurysm. This is AP view and lateral view. This is the rod mapping. And to start, I navigate inside the sac. This is a balloon remodeling. I put one balloon in this branch from this to here, a second balloon in the second branch. This is a distal balloon inflated, but you are a loop inside the sac. When you inflate it, the balloon, slowly you remove the catheter, the guide wire, to have this good position. And then you replace the balloon close to the neck. You start from some coils and look, this is the guide wire, this is the balloon in the neck, this is the coiling. I put a second catheter and balloon in the inferior branch of the middle cerebral artery, double balloon to double remodeling. But this is a picture to example of balloon. When you put the coil and you deflate the balloon, the coils go on to the neck. This is a danger, no? You are very, very careful to this situation. This is the reason when sometimes I use the stenting. When you are the morphological change of the coiling or the packing, you need to complete with the stenting. The aneurysm. I put one micro catheter, distal part. I put the stenting, Neuroform or Atlas stent. I remove the coils, put the stent in the superior branch. Here the stent in the superior branch, AP view. You have the stent. Also, I put a second stent in the inferior branch. Now you are the neck reconstruction. But be careful also, because when you remove the guide wire, it's possible you are a kinking of the stent and close the branch. This is the reason when I put the stent, I wait 30 minutes to check if you are thrombus in the vessel. This is the double stent here, at same here. Okay, the situation is, I think it's okay. And then I put the coils. It's a good, but you are a remnant neck here. This remnant, in my opinion, is better to wait 1 week or 2 weeks, because if you push more coil here, you are a mass effect in the stent and you are a progressive thrombus. This is the remnant neck. And I decide, wait, and in the second time, embolize this. But this is a control. And now I look this perforant branch. I put the coil in. Every time I check, don't have a kinking. And this is total fucking of aneurysm. And this is the final control and asymptomatic evolution. This is the reason when I put one stent where we place, every time, this is another aneurysm, you are a kinking in stenosis in this part of the terminal ACA. When place the stent, you are more possibilities you kinking. Only with this stent, the control is okay. I put some coils. I have a good flow in both branches, E1 and M2. But the patient developed paresthesia 6 hours later. The reason is a kinking. I come the patient another time, second time to the angio suite, of angioplasty to open the cells to go into this part. I open the cell in this point. This is the evolution. But this is another example of the middle cerebral aneurysm, oblique projection, AP, another oblique projection, some branch proximal to the neck. This is the change of the anatomy or geometry of the anatomy when you put a balloon or a stent. Look, this is the normal position of the vessel. When you put the balloon, you change the anatomy. And when the key point is you choose the best branch to put the stent or balloon remodeling to place the coils. When you remove the material, you don't have a geometrical anatomy. This is the control, a good resolution, and replace the geometry of the coiling of the middle cerebral artery. This is the final control. Late phase to look, you are very good flow. In the basilar is another example to look the kinking every time you are kinking. Be careful with the kinking of the stent. Okay. This is the example when I cross one or second stent. After to place the stent, you need to balloon remodeling inside to open the cell in place. After embolization, the coiling, some coil here. Replace a final result. Okay. The second example, a final example, is the complication of intrasaccular device web. This is a middle cerebral aneurysm with large neck, AP view, lateral view, and rupture aneurysm. There are some morphological change in the fundus, but it's not rupture. I talked with the proctor of the company of the web, and this is a good case. Okay, I think if you like, it's a good case. I'm going, but I think it's not a very good case because the direction of the neck is different to the intrasaccular device. This is the aneurysm before implant the web. The guide catheter going very high from here and then from this part. Look. When I have a risk of rupture, every time I place one balloon remodeling protected before, because if you are a rupture, you help with this balloon. When I put the web, the aneurysm is ruptured. And 4 minutes later, this is the web. This is the web. This is the catheter with balloon. This is the catheter, distal catheter with the web. This is a rupture. 5 minutes. Compression, manual compression of carotid. Reverse the heparinitiation, anticoagulation. And then I put inflate the balloon, I wait a little bit and stop the bleeding, but I have a risk to or rebleeding or change of the place, the web inside. I decide to put one stent to protect the vessel. This is the web. And this is the final result. You are some neck remnant. This is the CT scan in angio suite. Look, the web is in subarachnoidal. This is in the middle cerebral artery. This is in the subarachnoidal. This is the bleeding. Reconstruction, you are the neuroform or out of the stent. You are the web. The patient don't have a good evolution, 24 hours, stand up, no problem. But I don't like to use the endovascular device to treat the aneurysm. I think is, in my opinion, I don't use. I prefer to discuss with the neurosurgeon, your clipping, your bypass, whatever you want, or reconstruction, but this material is dangerous. And every time you have possibility to remnant neck, I don't like this device. Okay, see you have any comment or any question. Thank you.
So I can speak.
Okay, thank you, Louis. Okay, any comments, questions?
May I
Yeah, go ahead, Juha.
comment? Luis, thank you for. Can you hear me?
Yeah,
Yes, we can hear you.
Luis, thank you for sharing these 3 cases. So I have to say that if you travel from Madrid to Barcelona, you can take the straight way, but you can go also around the world and to come from Madrid to Barcelona, or in China you can travel from Beijing to Shanghai straight way, but you can go around the world and come from Beijing to Shanghai. So I think in these cases, which were simple broad-based aneurysms, the straight way is to do clipping, not to try to push something there or innocent vessels. You are doing extremely complicated. Of course, it is wonderful to push something inside and to occlude the sac, but the right way is to put the clip there. So these things which are pushed inside the arteries, they are extremely expensive. A clip is $300. So this is, I cannot understand, for example, in China, many of these aneurysms are treated by endovascular means. Of course, you can speak with the patients and tell that it is dangerous to open the head and so on. It depends how you speak and spread the information. But completely simple thing is that these broad-based middle cerebral artery aneurysms are best treated by direct clipping until something new is coming. So I think whatever is published here in WeChat or LinkedIn, successful cases, so it is not the general knowledge. This is my strong saying. I like you, Luis, because you are telling about the difficulties also, and this is not always heard by the endovascular information spread. This was my comment.
Thank you. Thank you. No, yes. Of course, I think it's important to present the difficult case or if you want complication.
But these were simple aneurysms for direct surgery. They were simple aneurysms, straightforward cases.
I agree.
No one can say that these MC aneurysms are difficult to clip. No one can say. If it is in well-trained hands by a microsurgeon, it is 1-2 hours operation. And here you push something many hours, and then you are afraid one day that something happens, what is pushed inside the vessels, arteries, or aneurysm. I think you should think. Of course, the patients listen to you if you say that we have to open the head, it is dangerous, we can push something there inside. Okay, this is how you inform the patients and how the general information is going around. But simple truth is that the clip in these MC aneurysms is the best treatment. My teacher, Professor Pieles, told that we continue to enjoy the perfect clip around the base of these deadly sacs. And this is extremely good sentence. It should remain in the mind of the neurosurgical world. So if something is good and perfect, it should not be replaced. Is my thing after doing so many. So you can push stents for $200 or euros inside the artery, but it's not good.
Yes, but I started in 92.
I'm speaking about MC aneurysms now.
Yes.
About...
No, MCA, only MCA. Okay. But I started in 92 to treat the MCA aneurysm with coiling, and in 2000 with the stent or before. The different situation. See, on rupture aneurysm, the patient, I talk with the patient, but I don't like open the brain. I free a neurosurgeon. Okay, I understand. The problem is not the method of the treatment. The problem is the neurosurgeon or the endovascular surgeon, and you choose the best to the patient. I agree with you. The rupture aneurysm is different situation. The different main point of the surgery is possible to treat it in acute phase. I have more than 4,000 aneurysms treated by myself. And more than 50% or more is in acute phase. And in acute phase is before 24 hours for me. At the beginning, in emergency, I don't like to embolize in emergency. I like to wait 6 hours or 10 hours because it's different to treat the patient at 3 o'clock in the morning or 8 o'clock in the morning. It's different. The important is the team. See, I have a good neurosurgeon in my team or in my hospital. Of course, the middle cerebral artery is not easy to surgery to endovascular. Totally agree. Also in the old patient, because you are the atrophy, cortical atrophy, you are more easy for neurosurgery. It's difficult to endovascular because you are the loop, you are the arteriosclerosis, you are the, it's complicated. For me, endovascular is good, to the acute phase of or is difficult aneurysms to surgery. But the surgery is depend of the neurosurgeon, not the surgeon. See, I have a good neurosurgeon in my hospital, of course. Go. Treat the patient. Why not? Is my comment.
Yeah, we are speaking about MC aneurysms now.
Yeah, MC.
Of course, not speaking generally, but
Okay, John,
MC
now
aneurysms
can you hear me?
Yes, we can hear you.
Okay.
Yes.
Let me try again.
Yeah, let me wrap this up first, Ben, okay? And then we'll. Okay. So can you take that off just for a second?
Okay.
Yeah. Okay, we'll end this broadcast for Louis. Thank you very much, Louis, and we'll probably see you next week.
Next week, whatever you want. Thank you very much.
Yeah. Thank you, Lloyd. Thank you.
Okay, wait. Professor Bean.
Hi.
Okay,
Hi.
Dr. Ben, it's all yours again. Let's try it again.
Okay. Now can you
I can see, yeah, and it's different than before. Yes, I can see it.
Okay.
Yeah.
So now I skip his video, and this is a type 1, the distal ICA to M1 segment aneurysm. It's a quite a large aneurysm. So we should replace the whole MCA territory and protect the perforators. So this is the territory we should replace the blood flow. So glomerular occlusion test is positive. So with SCP MEP monitoring, we change the position of the clips, including the permanent and the temporal clips, to make sure to keep the perforators intact. So this patient is use radial artery to MCA. So this is another one, more distal M1 segment giant aneurysm. So we get the proximal occlusion and combined with distal STA, ECA, radial artery to MCA bypass. We can see the radial artery was patent and the blood flow come to the M2 segment and replace the whole MCA territory. And this is type 2 unruptured M1 long segment aneurysm with a thick wall. This kind of patient, we can consider the distal occlusion combined with distal bypass. The blood flow replacement should cover 2 M2 branch. So we use temporal clip to clip the different branch of the distal MCA. Then we decide which is the distal branch of the superior trunk and the inferior trunk. Then we select the recipient artery and do the N2 side stomas. So this is the final result. We can see the double bypass was all patent, and the blood flow of the parent artery was totally replaced. So after 1 week, the CTA shows the aneurysm didn't show anymore. So this is a more distal M2 superior trunk big aneurysm. We can see this is a partially thrombosed aneurysm. And this is a dome of the aneurysm. We can see it's very huge, even bigger than the angiogram because it's a partially thrombosed. So before we resect the thrombus and reconstruct the blood flow, we did the protective bypass STA to M4 segment. Then after the protective bypass, I directly reconstruct the vessel cavity. Now actually the vessel cavity was reconstructed very well, so we can see the superior trunk now is in very good shape, and the final result is quite good. So this is a so-called protective STA bypass. So this is type 4 aneurysm resection combined in situ anastomose of M2. For this aneurysm, it's also a superior trunk big aneurysm, partially thrombosed. We can see, but it's the vessel is quite tortured, so they still have some space. After remove the aneurysm, we can achieve the end-to-end anastomose from the proximal to the distal part. So this is after the in situ anastomosing. We can see the vessel wall was totally reconstructed very well. So this is another proximal occlusion of the STA superior trunk combined with distal bypass. We can see the distal bypass replaced the superior trunk. This is also partial thrombosed big aneurysm. It's a quite a long segment, more than 2 centimeters. So this big aneurysm is partially thrombosed, and the dome's wall was very, very thick. So we only did the distal bypass, combined the distal STA M3 bypass. Sometimes we could even use hybrid treatment. you can see this is a M1 segment big aneurysm, and we can see the LSA was originated from the very close to the dome of the aneurysm. So we have no space to clip to achieve the proximal clip of the aneurysm. So I use the coils to achieve the proximal control of the aneurysm, and we can see all the perforators was protected very well at this segment, and the distal bypass was all patent, and the blood flow recurrent reflow to the M2 segment. So sometimes we the radial artery, especially the patients is short. Sometimes the radial artery was not long enough, so we can use a new graft artery, right GEA. So this is a M1 segment big aneurysm. I use a new bypass graft artery, right gastrical gastroepiploic artery. So this artery was quite long. Normally, it's the mean length is 22 to 29 centimeters. The diameters from proximal to distal is normally is 3.3 to 1.3 millimeter. So it's longer than the radial artery. So in this patient, it's long enough to do the STA, right GEA to MCA bypass, combined another STA MCA bypass. Then I trap the aneurysm. So this is the final result. We can see the two clips in the proximal and the distal part of the aneurysm, and the double bypass was all patent. So the right GEA is longer than radial artery, normally used as a graft for coronary bypass. Can also be used in cerebral aneurysm bypass. So this is a take-home message. Every MCA complex aneurysm should have a tailored plan for blood flow replacement and the protection of the important perforators. So the surgical plan, according to my opinion, should be as simple as possible, and the bypass time should be as fast as possible. The number of the stomas should be as few as possible. So one branch of STA can create double barrel bypass to increase the donor flow. Radial artery and the right GEA can be used if STA flow was not enough. The distal occlusion of parent artery only used in unruptured thick wall aneurysm with important perforators. MEP and SEP monitoring is utmost important. Intraoperative ICG or angiogram is very helpful. Thank you for your attention. Thank you.
Okay, thank you very much, Dr. Bin, for coming back and finishing. And any comments and questions from the panelists, please? Go ahead, Louis. Unmute yourself there, Louis.
Yes, thank you. Thank you. Congratulations, your presentation. One question. After bypass, the patient is by antiplatelet therapy or not?
Normally, just use aspirin.
How long?
For 1 month, yeah,
okay.
Maybe. Sometimes it depends, you know. Sometimes I don't use aspirin.
Mm-hmm. And you are the control with the pressure, blood pressure?
Yeah, just to the baseline.
Yes.
Yeah.
The level is about?
Yeah, keep the baseline with a preoperative level.
Mm-hmm. Thank you.
Okay. More comments, questions? Go ahead, hey, Daniel.
Yes. Do you have after you do use the radial graph after bifurcation? I mean, or just using distal or proximal aneurysm? I mean, when do you use the radial graph?
A radiograph.
Radial
Normally, yeah. The radiograph only used in the proximal MCA aneurysm. More proximal should be replace the whole MCA territory. Sometimes, especially in female patient, the STA was too small, and the blood flow was not enough for replace the whole MCA territory. This kind of condition we use radial artery. For male patient, normally, especially for the strong adult male patient, normally the double branch of STA is big enough for replace the whole MCA territory.
Okay.
Mm-hmm.
Okay, more comments, questions from the panelists before we close? Okay, looks like no one else has a comment or question. Okay, very good.
Okay.
Thanks for coming back again, Ben, and thanks for translating. And thanks for Juha and Lewis for the presentation. And we look forward to next week. And we'll edit this and get it into your hands. Okay, we'll see you next week.
Okay, see you.
Thank you. Bye-bye. Bye, Sachin.
Very good. I'm glad we were able to finish it, Ben. That was great.
Great. Thank you again.
Well, I'll give it to the editor, and we'll splice it together. So hopefully it'll look good. So you and Juha are going to get together on the translator, right?
Yeah.
And then let Juha know who is good, because he needs a translator. He needs a translator. And thank you thank you very much for all your help.
Okay, thank you.
Okay, we'll see you later. Thanks, Juha. Have a good week.
Thank you, John.
Bye-bye.
Bye-bye.